Thank you. Thank you so much for coming. Thank you to SAG-AFTRA for hosting us here. Thank you to our amazing group of people whom you'll learn a lot more about and hear from very soon. And have any of you listened to the podcast Script Notes? So we tonight are a podcast of Script Notes. How dope is that? My name is Marty Kaplan. I have the honor to hold the Norman Lear Chair at USC. And I'm thrilled to do that for so many reasons. One of them is what Norman has believed throughout his career, which is embodied in what we do and what's happening here tonight, which is, as he constantly is saying, stories matter. Storytelling matters. Stories make a difference. And if any of you, as a writer, is looking for a role model, Norman's series, One Day at a Time, was just picked up for its 4th season. He produced co-produced with Jimmy Kimmel, a live 2-hour special on ABC, which was a ratings breakout star. And on Saturday, he turned 97. So yes, we all want that. The Norman Lear Center is named after Norman because of his generosity to us. What we do research, and we also try to make the world a better place. It's an unusual mix for an academic institution, but we give it a shot. The research we do, it's a lot of projects, but what they come down to is we ask, when we see ourselves in the mirror of entertainment, when we see ourselves through the eyes of our storytellers, what do we look like? And how does what we see affect us? How does it inform what we know? How does it influence what we believe? How does it change what we do? We ask that question about stories, about virtually everything, about immigrants, about people of color, people with disabilities, people with HIV, about reproductive rights, about climate change, about nuclear arms, and tonight about addiction and mental illness and breaking the stigma about them. That stigma does not fall from the sky. I have to tell you, you might have seen this. A few days ago, the Wall Street Journal ran a very long piece about the Sackler family. And Richard Sackler was the president and owner of Purdue Pharmaceuticals that makes OxyContin. And because of a lawsuit, an email that he wrote became public. And this is just a little nugget of a quote that tonight's event, when I saw, I knew I had to bring here. He said, he was writing to someone, "I'll tell you something that will totally revise your belief that addicts don't want to be addicted. It is factually untrue. They get themselves addicted over and over again." That is a true story begging to be dramatized. That is a character begging to be portrayed. And tonight, you will hear lots and lots of facts and stories, which we hope will inspire you to tell stories that are informed by facts, but also are gripping and compelling entertainment and ideally make the world a better place. So the entity at the Lear Center, the program that is responsible for tonight's event and for all of our outreach to the entertainment industry, is called Hollywood Health and Society. And you will see around lots of people doing lots of things, and many of them are the staff of Hollywood Health and Society who work so hard, and they are led by the most amazing director who inspires them and inspires me, and she'll introduce our moderator this evening. Please welcome Kate Folb.
Hi, everybody. I'm going to make this quick because I know you don't really care about hearing from me, but I'm thrilled that you're all here. This is a topic that's very, very near and dear to my heart. I just want to do a quick commercial about Hollywood Health and Society for those of you who might not know us. For 20 years now, we have been a free resource to the entertainment industry, to writers, producers, and other content creators on all aspects of health, medicine, science, safety, security, and basically anything else that you have a question about. We are free. You don't have to pay anything. We don't take a credit. We won't ask for a signed script or a walk-on from our daughter-in-law. We're really here to serve you, to help you create the most accurate stories possible around those topics. We're not going to try to influence your point of view on it or anything. We just want to help you get the facts right. And so we're here. Call us, email us. We have operators standing by to take your calls. We can connect you with experts like those that you see before you, as well as many others in many other fields. And we're here to help. So please call us, email us. We're happy to help. That's my commercial. So welcome again to this discussion on breaking the stigma around mental health and addiction. This panel is amazing, I know, and have spoken to all of them a few times now, and if not more than that, and they're all fantastic. And we're just so thrilled to be partnering with Script Notes and with John August. I'm so thrilled that he's moderating and not me. So I'm just going to turn it over to John. So thank you, John. Welcome.
Hello and welcome. I have to start everything with hello and welcome. So my name is John August. I host a weekly podcast with Craig Mazin called Script Notes, and we talk a lot about writing and things that are interesting to screenwriters. And as we talk about screenwriting, we're always trying to focus on specifics, like what is the specificity of this moment? What is the reality behind this thing? Why are characters doing what they are doing? So we will talk about the words on the page, but we'll also talk about the experience of watching the stories that we're trying to tell. And we'll bring on guests sometimes to talk about very specific things that they would wish we as writers could do a better job at. We had Rachel Bloom on recently to talk about how we portray sex on screen and how we can portray sex more realistically on screen. So when I found out this panel was happening, I virtually threw myself in front of Kate to say, like, hey, do you need a host? Because I really wanted to talk with these very smart people about addiction and mental health. To do another thing we talk about on Script Notes a lot is structure. So let me talk a little bit about the structure of tonight's evening. I want to start by talking about the experience of a character facing addiction or mental health challenges, then talk about the characters around them, sort of how that character is impacting the world around them, then step outside a little bit and talk about how the stories we tell are perceived by the world out there, and what is our responsibility, what are our opportunities as we're telling these stories. And finally, look at sort of the broader picture of what is, as we're talking about addiction and mental health, how do we as creators have to be mindful of our own mental health and things we can be looking out for ourselves. So that's sort of the structure for the evening. There will be questions and Q&A at the end. So if a question comes up along the way, remember it, because we will get to that at the end. But I want to start by talking about sort of how our characters come into our stories. And I want to start with you, Gemma. So Gemma Baker is a writer and producer and the co-creator of the hit CBS comedy series Mom, a show lauded for its portrayal of addiction. She previously wrote on 2.5 Men, graduated from the Tisch with a degree in theater. Gemma, welcome very much. So,
hello. Hi, everybody.
My question for you, so the two lead characters on Mom both have addiction issues. How early in the process of coming up with Mom did you know that this was a thing you were going to want to explore?
In the very, very beginning. So when it was first being talked about, the idea was for the character to be a mom who has addiction, active addiction, and drug problem, and then they knew that they wanted, it was Chuck Lorre and Eddie Gordetsky, and they wanted to do a show about a mom, and they thought, we're going to bring in a mom, and they asked me if I thought that could be funny, and I just thought, well, if people don't think that the kids are safe, they're not going to feel okay laughing, that. And so what if the character was in recovery and you could root for her because you knew she was trying to change? And so that was our starting point.
What was the starting point for your research into this? How did you find out about what recovery would look like and sort of where the opportunities were and where the challenges were for these characters? What was that research process like for you?
I think one of the things that was really important for us was that a lot of times when recovery is portrayed, not necessarily now, but then, it felt like it was dreary, and that there was no joy and light, and there wasn't a lot of hope in the portrayal of it. And I think that is what we felt was missing, and that anyone who knows and loves someone in recovery knows that that's such a huge part of it. And also, so often recovery is the end of the story. You watch a whole movie about addiction and it's so awful and painful and heart-wrenching, and then at the very end, it's like, and then they got sober at the end, roll credits.
Sometimes there's even a nice little title card saying,
and
like,
then they got sober, it worked out.
Yep.
And I think that that recovery is not the end of the story. It is the beginning of the story. It is having a chance. It is where it's the beginning. And so we wanted to tell a story that started there. That was really important to us.
That's great. Let's talk more about recovery. So our next guest, Dr. Corey Waller, is a nationally recognized addiction expert and currently practicing specialist in addiction, pain, and emergency medicine. Through his work with the Health Management Associates and the National Center for Complex Health and Social Needs, he has developed addiction treatment methods, provider training, and educational outreach delivered by that center. Dr. Corey Waller, thank you for being here.
Thanks.
We're going to be talking about addiction and mental health, and because you're the actual doctor here, can you help us get our terms straight? When we say someone's dealing with addiction, what does addiction mean in a medical sense, or what's helpful for us to be thinking about when we say that, use the term addiction?
Yeah, no, that's a great question, and I think a lot of people misinterpret what addiction is. And addiction is not the presence or absence of a drug in somebody's system. It's the way in which they behave in obtaining and using the drug. And we actually define addiction based on 9 very specific behaviors, and that means they're predictable. I mean, in the Diagnostic and Statistic Manual, we've identified 9 specific behaviors associated with both drugs and or a behavior like gambling that ultimately tell us whether or not someone has addiction. And we can use those behaviors and the presence or absence of those to determine how severe it is. And so with that, that's how we create our interventions and have done all of our testing to identify how to appropriately treat people at the beginning, because they have predictable behaviors that we identify as addiction. And unfortunately, those behaviors many times are misinterpreted as frustration or anger, when in actuality, they're just symptoms of a disease. And so I think that's the big piece around addiction, is that it's definable, it's identifiable, and it's not because somebody's mean, or it's not because somebody got drunk at a party, and it's not because somebody used cocaine on a Friday. It's what does that look like in their life in general? And do they have control over that drug? Do they have control over their behavior when obtaining that drug? Do they try to obtain that drug over their safety or over the safety of their kids, or do they lose their job because of the drug? These are the ways we define it. And so many times that term is slung around in a pretty messy way. But medically, we have very specific criteria for what addiction is. And we actually know more about the neurobiology of addiction than any other chronic brain disease.
So as we're talking about terms, what addictions can have a pejorative context, like someone has, and we need to get past that. That's the stigma thing we're trying to get past tonight. But a word like addict, is an addict a useful word or not a useful word? What's helpful for us to be saying when we're talking with somebody who's dealing with these issues?
Well, person.
Yes.
I think we just start with that. But in general, people aren't defined by their disease. We've gone really far to make sure that people with diabetes and cancer and other medical illnesses aren't defined as their disease, because they're a person with that disease. And the disease is just, it's a part of who they are, but it's not how we define them. So we don't, in a perfect world, call them addicts. We call them a person with addiction. And then we can get very specific in healthcare terms. They have an opioid use disorder or a substance use disorder. Terms like clean and dirty, those are terms that are utilized that have no medical connection whatsoever. Even like a urine drug test, we talk about they dropped dirty. I have doctors say that. There is no clinical terminology that, what does that mean? It got mud in it? I don't really know. What we have to start doing is not taking on how the patient's very self-stigmatizing language is utilized. And it's used a little bit to combat the shame and the fear of this disease, and not take that language and somehow weaponize it toward them. Because as people in healthcare and even just society in general, using a term like a person with addiction is what it is. And that's where I think we should start.
And thinking about this as writers, as we're coming up with character descriptions, we're trying to describe what a character is like. If we use a word like addict that just like stops us dead, it's very hard to see anything else around that character. We're not seeing what they're doing. We're not seeing the choices they're making. It's taken all the agency away from that character. And so, finding the right words to use feels really important. The other part of our panel tonight, our discussion, is about mental health. Where are the overlaps between people who have problems with addiction and mental health things? Is there a big crossover between the two?
Yeah, and so the crossover seems to really be identified in those with what we call adverse childhood events, so early life trauma. I ran a clinic dedicated to pregnant and parenting females, so we saw hundreds of females who had addiction while they were pregnant. And all but 2 of those hundreds had a significant early life trauma, most of that sexual trauma. And so the early life experiences that occur to someone increase the chances of them having not only addiction, but a co-occurring mental health disorder. And that mental health disorder, if not treated while you're treating addiction, will make the addiction unstable. And if you're treating the mental health disorder on one side, but not addressing the addiction, you're never gonna get the addiction stable. So it's a matter of most people who have addiction also have a co-occurring identifiable mental health disorder. It's unclear early in treatment if that's going to be there after we stabilize them in treatment. And so you have to go through a pretty significant process. But quite honestly, as you'll hear, one side doesn't necessarily talk to the other. You hear, I treat addiction, or I treat only psychiatric ailments. But rarely do those ships meet in the night. I mean, honestly, it's crazy because that one book has all of the descriptions, and a third of it is about addiction, but then there are psychiatrists who are like, I just kind of ignored that part and moved on. And then addiction medicine providers who don't read the other stuff. So it's very disconnected where it really shouldn't be.
All right. Let's keep looking for that crossover. Our next guest is Dr. Holly Daniels. She's the managing director of the California Association of Marriage and Family Therapists, supporting 32,000 clinicians. She's worked as a clinician, teacher, therapeutic consultant for over 15 years, specializing in addictions, eating disorders, and other mental health issues, using her extensive knowledge of treatment programs on university and college campuses to help young adults thrive. She received her Ph.D. in psychology from Sophia University. So you're working with younger populations. What are some things that we as sort of older than college students might not be aware of, that are happening on campuses, college campuses and high school campuses? What do you see that we may not be aware of? What are the things that young people are facing?
Well, there's a really interesting actually dynamic right now in that our society as a whole has embraced talking more about mental illness in general and substance use disorder, and that's really prevalent in the younger generation, right? So kids are actually talking more on campus about their mental health issues, about having anxiety, about being depressed, and there's more of a discourse, and I would say, thank you to television and film actually for opening up a lot of that discourse. Kids feel more free to talk about it, but there is kind of that backlash of the more they're talking about it, and there isn't really the science-based support to help them through it, right? There's still a lot of issues with drug and alcohol abuse, from age 10 up, and there really isn't, unfortunately, enough support in our school systems or in our education system. And the education that they're getting about mental health issues and substance use issues is coming from the media, right? I mean, that is their discourse, the film and television and what they're watching. And so, sometimes it's a really helpful education. And I don't know if anybody has seen 8th Grade, but I loved 8th Grade by Bo Burnham, which talked a lot about anxiety. We have shows like Euphoria, which I'll talk about that later. I have different ideas. I have thoughts too. But overall, I would say the big positive is that, just like Corey was talking about, we really need to change as a society and stop penalizing mental health issues and criminalizing substance use. And the great thing is when we can see those stories in television and film, and we can see people having compassion and leaning in to support the people who are struggling, that gives our young kids, our adolescents and our young adults that model to be like, oh, if somebody's struggling, I reach in and help. I don't call them a bad person or say that they have a moral failing, or I want to help. And that's actually really a hopeful thing that's happening on campuses, is that kids want to help each other. They want to be there for each other, and that's a beautiful thing.
Yeah, I definitely noticed that teenagers want to help each other, but sometimes don't have the actual skills to be helping each other. And to what degree do we need to be aware of contagion, or sort of the sense that like a person with a challenge spreads to others? Like how, as a person who's dealing with young populations, what are some things that we have to be aware of with teenagers? Are there different things that happen with them than?
Yeah, it was such a good question, and this is why the work that Hollywood Health and Society does is so important, and being able to, as film and TV writers, reach out to experts to understand where that fine line is when you're portraying heroin use or when you're talking about kids committing suicide. What are the things that you can do so that the visuals, right, are not more triggering than they need to be, right? It's a fine line if we want to be able to talk about this and we want to be able to portray it, because that's important, but we also don't want to cause children out there to hurt themselves, right? Or create an atmosphere in which they feel like it's glamorized or it's cool to self-harm.
So finding that balance between realism and glamorization is a challenging thing, and we'll keep talking about more of that tonight. But I want to introduce Zachary Siegel. He is a journalist who covers public health, mental health, and criminal justice. His work has appeared in the New York Times Magazine, The Atlantic, New Republic, Slate, Wired, and Political Magazine. He's currently a journalism fellow at Northeastern University's Health and Justice Action Lab, where he has spearheaded the Change the Narrative project. He co-hosts Narcotica, a podcast about drugs that's informed by science, policy, and the lives of real drug users. I have a rival podcaster on the panel. I'm not sure if
That's okay.
That's why we put them as
We are hoping to steal this audio too for our own podcast.
All right,
so we'll talk later.
It all crosses over. Zach, can we talk about sort of your experiences with addiction and sort of the degree to which Hollywood and the things you saw in movies and television influenced the start of that, the progress of that, the recovery from that? What did you see as you were encountering it for the first time?
Yeah, so I'll try to keep this brief because it's a long story. So full disclosure, when I was about 17, had a opioid use disorder, as we'd call it now. And it really started with friends and I exchanging pharmaceuticals, and really what happened was, as a young, anxious, sort of nervous, like Jewish teenager trying to figure out what the world was like, I took an opioid and finally felt normal. Like I finally felt okay. And it's a cliche at this point, but it is really true. When most people take opioids, they get kind of itchy and constipated and they don't really like them. When I take an opioid, it was like, okay, the clouds have parted and I feel very, very comfortable, which can be a very dangerous feeling for a teenager. And so that progressed and progressed and progressed all the way up to heroin use, but to not like bore everyone with that story, because really I was just like watching movies, like pretty zonked out, like 5 hours a day. It was not a productive time of my life. But I did watch a lot of media, so I can talk about, for example, like how like maybe the first time I ever saw injection heroin use on screen was Basketball Diaries with Leonardo DiCaprio, and I think that had a huge impact on me, and I wanted to be a writer and be in like sort of the beat, scene in New York, and that whole thing was very attractive, but the sort of delusion that has to be confronted is like people on drugs typically, life is really hard and you can't necessarily be productive. Like I was not a successful writer when I was using heroin because I had to think basically in 6-hour timetables where, okay, here's one fix and where's money for the next one, and to live in this sort of collapsed time where you're very much encased by the next one and the next one, it was incredibly difficult. And so I can talk more about media, but yeah, I do think the way that I consume media and the things that I saw were very impactful. One, it may sound random, but there's a documentary called Methadonia produced on HBO. I don't know if anyone saw this, but it was a horrific portrayal of a drug called methadone. And just the quick facts, methadone saves lives. It reduces someone's risk of fatally overdosing by 50% or more. And this documentary, however, portrayed it so negatively, and I think I was a teenager watching that before I had ever really thought that one day I might need this drug. But as the recovery process sort of unfolded for me, and I didn't wind up in a methadone program, I had to confront my own stigma about people who take methadone because of that documentary. So these things have. It's just a huge responsibility to portray this.
So I thought we would start by talking about the experience of a central character in our story, so either a movie or a television show, who's dealing with an issue, and sort of talk about the time frame, the things, the challenges, what are the realities there, so we can then think about how we're going to portray them and sort of what are the opportunities. And so my hypothetical character I want to introduce is a character named Jane. She's 28, boyfriend, not married, an alcoholic. And we can talk about sort of where alcoholism is. And I use the term alcoholic. I probably should use a person dealing with alcoholism. This is where the character is that we're meeting. But we could meet her at many places along the spectrum. So Gemma, you decided for your show to show somebody who is already in recovery. Corey, can you talk me through, someone who's dealing with alcoholism? Where are some points along the way we might meet that character? Like, what are the stages where we might meet a character who's grappling with it?
Well, I mean, a bar.
Yeah.
It's a common location. But so a couple of things with
time span. It's sort of like what are the stages of life, stages of
I know. So as we look at this, alcohol use disorder is the most prevalent addiction, period. You add all the other ones together, it's still not as many people that have alcohol use disorder in the country. So it is still the most prevalent, but it's also the one that is more normalized. And so people can go to a bar and get barely able to stand or walk, and we'll call them an Uber and send them home. But we don't think about that in the context of alcohol use disorder a lot. That's, somebody tied one on, or, you're hungover this morning, or that kind of piece. But generally speaking, the first time that we interact with them in a healthcare setting is going to be when they accidentally fall and break an ankle, or they get picked up by police and are incoherent and show up. I'm an emergency medicine doctor. I still practice, and so I'll see people in the emergency department, and that's how I first encounter them many times, as intoxicated. And just being intoxicated doesn't mean you have an alcohol use disorder, but it starts to really add up a lot of those points that we talked about when you are intoxicated and you fell and you hurt yourself and you ended up in an emergency department because of the intoxication. So it's not always just the homeless intoxicated person who shows up to the emergency department. This is the early part of the disease means that there are times in which things are stable. They're still able to generally go to work. They're still able to have an interaction. They're still able to have friends and connections. And over time, those things start to wane. So that first time that we get them is the best time to intervene because we generally have a milder disease than if we wait this out. And so this concept of they'll come and get help when they're ready, or this concept of rock bottom is basically means we're going to see if they wash out through dying before we treat them. And so the times that we're going to interact are going to be the times that they drunk dial mom at 3 o'clock in the morning. The times that their boyfriend confronts them because they're frustrated about how they embarrass them at these places. Or the boyfriend or significant other also has an alcohol use disorder, and maybe they're perpetuating this. And so those are the times that we're more likely to make the biggest difference in someone, are those early signs of addiction, which is they're missing work. And so as I have a staff of 30 people, and I was the chief of pain medicine for a health system, so if a doctor started having odd behavior, I would pull them aside and have to be like, what's going on? You know, we are scared to do that in society. We're scared to call people out because we don't know how to do it many times. But an empathetic ear and somebody just saying, I care about you, if you want to chat about this, really opens up the door for that early interaction to occur. By the time I get them, I mean, the train has crashed at that point. This is a point where they're either mandated by court or intervened by family, or their life is in complete shambles and they have nowhere else to go, and that's just too late. And so I think recognizing that 60% of people who at some point meet for an alcohol use disorder self-resolve. So I always use the anecdote of when I was in college, I tried really hard to be an alcoholic. It just didn't work. And that's good for me, but that's a lot of people. If you think about back in school and that, the number of people who drank to the point of failing a class or missing class or failing out of college, but then kind of bounced back. Early in life, in adolescence and in early adulthood, we have kind of resolution of an acute version of addiction. Now that is an increased risk for later that something may recur. But if you can catch them at that phase and really kind of work with them, we don't necessarily have to even label them long term. I mean, I have a roommate who drank just as much as I did. He has a label of an alcohol use disorder, but I don't. We have the same trajectory in the end. So it's just a matter of when you catch them. So I think early, and it's those little pieces where we find them the most. And that's where they start to struggle with isolation, which we find is the early form of kind of the fear and stigma they put on themselves. And from a character perspective, being able to portray that shame and isolation that occurs very early in this disease, that is the path to the more severe version of the disease that leads to bad outcomes that I would see. And so that guilt and shame keeps them, they hide, they start to drink alone, they start to separate from people, go to different bars where they're not going to be noticed. And it's not a control issue. It's a part of the brain. It's this, we know exactly what part of the brain it is. It's the default behavior for an input called cue-associated relapse. And it's not a decision like we think about. It's not a pros and cons sheet. It's a reflex once they've started using.
Gemma, he's talking about self-stopping and sort of control, and we always, as we write our characters, we want our characters to. We're sort of cruel gods, aren't we, as writers? We're always creating these challenges and obstacles for our characters to face. As you look at the characters you're dealing with in your show, how are you, as a writer and as a writer's room, talking about characters' awareness of the behaviors that they're doing, awareness of the problems that they're encountering for themselves? Because it sounds like, any one of the characters we set off in our stories could end up in a very dark place, and yet you are mostly responsible for getting them back to a good place by the end of 30 minutes. So how are you talking about that in a writer's room? How are you figuring out sort of, how to get a character through these situations?
Well, I think, one of the things that sitcom characters are not known for is growth and change, right? So, but we have this amazing opportunity and I think responsibility to say that these characters, now we're going into season 7, they have grown, they have changed because they're sober and because they're facing life in a new way, and because they're doing it together, and because they're using certain principles to change and grow. And so I think that's been really fun. When we feel like they're starting to get stuck, that we're like, oh, that's season 2 Bonnie. That's not season 7 Bonnie. Season 7 Bonnie is going to handle that better. So we keep ourselves sort of accountable to that. I think also we have, because we sometimes have, the actual meeting, portrayed, we have this device of people sharing. Also on a sitcom, you don't necessarily see someone just tell you where they're at for 2 minutes, but we have that ability to do that because our characters literally are sharing where they're at. And so that helps us to, they might begin their share thinking one thing and then hear something and get to another place quickly.
So the idea of a group meeting, a 12-step meeting, or some other place where people come in and just describe what they're going through, is that being portrayed realistically in most of the things that we're seeing? I'm sort of asking other experts here. Are those meetings being portrayed the way you sort of wish they would be seen? Because I have a hunch that we're optimizing them a bit for our narrative use than what they would really be. Holly, could you speak to sort of like what the role of group meetings is in Jane's life? Let's say that Jane is making progress. What would that meeting really be like, and what are the things you don't see that we might be showing better?
Well, yeah, there's really huge power in group share, and that's why the Alcoholics Anonymous movement has been so successful, actually, in helping a lot of people get sober and get better. And it's a place where you can feel like somebody sees you, right? And somebody gives you space to be who you are and be going through what you're going through. And that is huge, and that actually is what television and film does for us too, right? When there's a representation in a television show or a film of what we're going through and how we can identify, that's just so very powerful and empowering. And so when we're working with people who are dealing with mental health issues or substance use issues, definitely we want to employ groups. And as an individual therapist, I would definitely, and do definitely encourage my clients to find a group and to utilize the group and the support of the group. But that is on the kind of on the recovery side. And I did want to mention, and maybe you're going to get to this, John, but like, what I would like to see more in film and television is the group that the person is with while they are in their addiction, while they're really struggling, because we are systems people, right? We're in a system, and there are always people who are enabling or ignoring what we're going through, or, you might meet Jane at a bar, but then, fairly soon you're gonna meet Jane in her room drinking by herself, and she's waking up and shaking, and her boyfriend's going and buying her some alcohol because he wants to help stop the shaking, but he doesn't realize that he's actually perpetuating her illness. And there are some really complex dynamics that go into the system that is supporting the person who is struggling to continue to struggle, unfortunately. And that's something that I haven't seen really, deeply portrayed in all of its complexity, which would be really neat to see.
Zach, what has been, as you watch film and television, and you watch individual therapists or you watch group settings, what are we getting right, and what do you think we're missing? And sort of what is the ideal role of the expert, the therapist, the person who is there to help the person? Again, I think we idealize them so much in Hollywood, but what is the real function of that person that you see?
I think to, first and foremost, actually, be scientifically and medically accurate and grounded as any expert in this field treating addiction should be. And that means oftentimes not sending people to Malibu for 30 days and pet horses on a ranch. Like, that is not how we treat any other addiction or any other medical condition.
I used to work at one of those places, so I take offense.
Sorry. But especially in terms of opioids, which it's on my mind a lot, there's an overdose crisis, and I think that there's a lot of opportunity to communicate health messaging with media by having a therapist say, you know what, actually, you're a perfect candidate for buprenorphine, and let's get you to the right doctor who can prescribe this drug. And you know what, maybe when you go to a recovery meeting or a group share on buprenorphine, you might be stigmatized because within this community, frankly, they don't often have the most science-based approach to things like medication. So I think to see that play out in a narrative would be very powerful.
Well, I should say, writers, we love conflict. So if there is a conflict that can be introduced, that could be a useful thing. And do you
This
agree?
one has been going on forever.
Yeah. But I would say that most people don't realize it exists. So.
Yeah, well, I think two pieces that I would pull out is one, for our 28-year-old female character, she's prey in these settings sometimes. If you get into the wrong meeting and you're very unstable in your disease, People that are also unstable in their disease can be a predator in that setting. And so it can be very unsettling for that person to show up to that meeting to someone who seems to get them unlike their boyfriend or maybe unlike their parents, and they use that angle to actually connect themselves in a pretty pathological way. And I've seen that happen a number of times for females in recovery going to some of these kind of to some meetings. So they need to find the right one, right? It can't just be any random place. And I think the other portion is to understand that everybody has their path to recovery. But at this point for opioid use disorder, 12-step abstinence-based treatment is only 8 to 12% effective. Now, for alcohol use disorder, it has a higher rate of effectiveness. But the research was done on, generally speaking, doctors, pilots, and lawyers of white origin. So when we start to think about what modalities we're looking at and what the data looks like, that data looks very clearly good for doctors, pilots, and lawyers, especially those that are Caucasian. It's about 85 to 90% effective for alcohol use disorder. But for the population that I see when I was in Camden or when I was in Detroit or Philly, wherever that is, that's not effective treatment for them. But it's also about timing and dosing. So thinking about somebody who's really unstable, that's probably not the best time for that. We do find, however, when they need to reconnect, that may be the perfect time to add something like that. So just recognizing that it's not the default treatment for everybody. Most people get treatment outpatient. Most people don't go to residential treatment. Most people get their treatment in an outpatient setting just like they would for congestive heart failure. So sometimes creating less conflict with it, because there's plenty of conflict in their life otherwise. Yeah. So the treatment of their addiction doesn't have to be the conflict point. There are so many other pathways because this disease is such a socially connected disease. It creates conflict in families, conflict at work, conflict in just going to the store and walking past, beer. I mean, those are conflicts that are there. So creating the conflict in the treatment sometimes stigmatizes the treatment. So I think it's a little lazy, to be honest, because it's not the place where drama has to be. We know how to treat it. I mean, we have effective treatments. It's pretty matter of fact, and we know how to know where they go. I mean, so that part of it and understanding where meetings are and what role they do play, it's not the treatment. It's just a part of a larger, normal approach to treatment that we would take.
And yeah, if I may add to that, Corey, I agree. And not only is it a place where people could be preyed upon, or but it also is a place that you actually don't want to go into a group setting to piggyback off what Corey said until you really are stabilized internally, because it might be very difficult and re-traumatizing for somebody to hear everybody else's stories about their trauma, right? And when we're talking about trauma, I'm not talking about getting shot with a gun or run over by a car. I'm talking about complex emotional relational trauma, we call that, which goes back to the adverse childhood experiences, which so many of the people struggling with substance use have. And so you have to maybe work one-on-one with medication, get yourself stabilized before you go into a group where you're going to hear a bunch of stories about a bunch of other people's really difficult times, because that can be very triggering and re-traumatizing. Yeah.
Which is, by the way, you guys Portrayed. It's the only show I can actually watch with addiction, to be honest.
Love
the
your
rest
show,
of them
Gemma.
are triggering to me, honestly, as a practitioner. Frustrates me and gets me angry, so I can't watch it. But but this one is one that does it in a way that people in recovery, they do well in those situations. So.
Well, I think it's because you're offering hope. Because you're offering that there's characters who deal with a thing, but it's never going to be completely resolved. It's not like the monster is ever fully killed, but they are, they're able to have productive lives. Mm-hmm. And that's obviously an early decision you made that you've been able to keep up for 8 seasons.
Yeah. Yeah, to be able to watch someone's life get bigger, to have, our main character, if I could go back in time, in the pilot we said that she wanted to be a psychologist, and then we quickly changed her into a lawyer. If I had a time machine, I would go back and just correct that one line in the pilot to say she wanted to be a lawyer, but I can't. So we just ignore it and pretend that her dream was always to be a lawyer. Yeah. And but she, we get to, and it was important to us to do that. It's, it takes a while to become a lawyer, and it's hard to write becoming a lawyer stuff, but we're doing it and make it funny. But we're doing it in real time because, we hope, that we are going to be on long enough to see that happen and to watch that whole process, and for her, the ups and downs and the doubts and just showing up for all of it sober.
Cool. Let's try and experiment with a different character. Carlos is 35. depression. And so this character who's dealing with depression, what things will we see outwardly as we're looking at the character of Carlos that might tell us that he's dealing with depression? And what, so if you can help me figure out both his inner state, so what he's going through, but what externally we would see for Carlos. What would be the things that we would be noticing? Holly, do you have a sense of like what we'd see first?
Yeah, I think that, it's not totally unlike symptoms of substance use disorder in that you'll see changes in behavior that suddenly Carlos isn't around very much, or he made plans and he didn't keep them, right? That his circle will notice that he's just not feeling up to doing the regular activities that he might wanted to do. And if when it really progresses, he might lose his job because he can't get into work and he can't get out of bed, and doesn't want to return phone calls, doesn't want to, and maybe then when is confronted, is able to like buck up enough to be like, I'm fine, everybody, don't worry, I just need some time alone, don't worry. And it really takes a supportive person in Carlos's circle to say, you're not fine, can we help you get some support? Because depression is one of those things, it can be a little bit under wraps. People can be really struggling with depression for a really long time and still show up to life just enough that they're not going to get into a car accident or break their ankle or do something that's so big because of being high or drunk that it can really go under the wire for a long time, and that's what's so scary about it too, and especially if Carlos starts to become suicidal, and most people who die from suicide don't leave a note or give any signs beforehand, and so it really takes a community, right, to be around Carlos to say, hey, this is the fourth time you haven't come out, and you usually came out with us and ate dinner every Friday night, and now you're not doing that anymore. What's going on, and can we help? Because Carlos can hide it for a good deal of time. Mm-hmm.
Quite a few people I follow on Twitter self-identify as being as dealing with depression,
Mm-hmm.
and they'll talk about the medications they're on. They'll talk about the struggles that they're going through. I admire them for doing it. Is that useful for them? Is it useful for everybody else? Like I always wonder the degree to which self-identifying as this can become an identity of being a depressed person. Mm-hmm. What is the current science and best thinking in terms of when a person who has depression is in treatment and is improving, talking about it? Like, what is the best way to interact with that character? Let's say Carlos has started getting some help. What do we do with Carlos right there, and what changes do we see with Carlos?
That's a really good question. It's a personal question, right? So sometimes the diagnosis can be really empowering, and it's something that you can share, and you can say, oh my God, this is what's going on with me. I have this chemical imbalance, and it is a disease, and it's an illness, and and so it's a little bit freeing. For some people, having a diagnosis is very shaming, and it's very difficult for them to carry that with them. So that's part of our job as mental health workers, to kind of be there with each individual and decide, is this somebody who is going to feel empowered with the diagnosis? Is this somebody who's going to feel shame with the diagnosis? And to be able to talk through all of that with them. But for the most part, I think it is, for the people I've worked with, it's empowering, and it's a way to build community, because mental illness and substance use disorder, they are isolating. That is one of the things that happens, is people become more and more isolated. So if you can say, hey, I'm struggling with this thing, and find other people in the community that say, hey, me too, and you can have that back and forth and connection, it can be really a powerful help. Yeah.
Well, let's broaden our discussion and talk about the community around Jane and Carlos, and sort of how they're interacting with family, with friends, with the medical establishment, with the police. What do those interactions look like? So we talked about earlier about Jane would come into a medical situation because she'd broken her ankle, or the law enforcement, if she was drunk driving. There's natural ways to do that. How would Carlos come into a medical community? How would he come into a law enforcement community? Like, what are the interactions that we see with these characters as they're as they're doing their thing and the impacts they're having around other people. Zach, like, what do you see as, Jane's? We talked about sort of her initial sort of circle, the circle that she was drinking with, the circle that was helping her stay there. How do we portray them responsibly and accurately? I mean, the people who are in some ways helping her stay the way she is.
I think it's super contextual, and I think just one very recent example of portrayal of depression is Euphoria, and in a recent episode of Euphoria, so Rue is the main character, and she is so depressed that she has watched 22 hours of Love Island straight, and there's this sort of ongoing, very painful experience of being too depressed to walk up to go to the restroom. And so her bladder begins to hurt. And so I think one thing that was really interesting and somewhat playful there was that depression hurts. It's not just an emotional, psychological pain. It is physical. Like if you really miss someone, it hurts when they're not around. And I think that having different ways of portraying psychological pain manifesting as physical pain could be an interesting thing to show on screen.
I would say that the science backs that up 100%, because the two chemicals responsible for depression are norepinephrine and serotonin, these two chemicals, and dopamine can play a place in one type, but those are also really important chemicals in pain. So in theory, if you have a low serotonin level and a low norepinephrine level, you're going to have depression. We find this really commonly. Interestingly, if I decrease those in the spinal cord, that also makes your pain sensor higher. Everything hurts worse, literally. So when somebody has depression, almost always they have physical pain. And it may manifest like a chronic injury. Right, no, exactly. And then here's an opioid, and I've just wrecked your life. So the piece is there's really hard science to back up physical ailments that go with anxiety or depression. The place in the body with the most serotonin is not your brain, it's your gut. So this is why we see nausea and stuff in people with low serotonin states, because it's not working properly. They don't digest food properly. It's one of the most common complaints I would get for patients with depression. They wouldn't complain about being sad or crying. They would complain about their belly. And then when you dig into it a little more, it's major depressive disorder.
Especially for young kids, right?
Absolutely.
That when a young child is dealing with a mental health issue, they're almost always going to tell you their stomach hurts. It's a big thing to know.
Great. So let's talk about a young child. Let's talk about a young child dealing with depression or anxiety or these issues. How do we portray parents? Well, what are the idealized perfect Hollywood parents, and what are realistic parents that we're maybe not seeing as much on screen? Holly, what's your take on those parents?
The perfect parent would say to their young child, how are you feeling? Can you talk to me about what you're feeling? If you can't use words, can you tell it? Can you give it a color? Can you describe it in some way? All feelings are welcome here. We want to talk about all feelings. They're important. Your feelings are important. And if you're having some painful feelings, or if your stomach keeps hurting, well, guess what? We know where we can go and find some help and find somebody who can support you and help you feel better, because your parents, we're here for you, but we don't have all the answers either. And sometimes we hurt too. And so let's go to the experts and find somebody who can help us out.
That's the perfect. That's the dream. But let's talk about sort of more realistic things, because in real life, parents don't know what they're doing. They're busy doing lots of other things. They have jobs. They have other stresses. They are going through their other issues. On your show, Allison Janney's character is an addict dealing with addiction herself, and has a daughter dealing with it. So, and yet you're trying to be a comedy. So how do you find the balance of talking about these things and still finding the funny in there, and dealing with the fact that she's not a perfect mother?
We don't have perfect parents
Yes.
on our show, no. I think that's why people like it. I think it's a relief. I think I don't want to, after I've made a mistake as a parent, tune in and watch a perfect parent. Like, that just makes me feel worse. It really just, oh, I could have done that, and I didn't. I like characters that are flawed, that are trying, but who fall down and make mistakes. And I think that is where we find humor, is in the trying. And, you know, we deal with a lot of difficult subjects, and those are the scripts that I want to write. Those are the ones that are so much fun because there's something to hold on to. And those are the ones where, you know, you can go into some really deep, painful places. I've always loved like a lot of sadness in my comedy, which did not make me a successful stand-up. But I found a place where it's working. I think that's, I don't know, I think that's the fun stuff to write, the pain.
And there's also a lot of fear. So I know as a parent, like there's also a tremendous amount of fear. So it's not that you're just ignorant to sort of what's going on, but you're also afraid of what's going on. So you're afraid of, you know, is this a small thing or is this a giant thing? And like sort of where does this all lead? And one of the other fears is the cost of things. And so if you are, you know, if we have a character with a child who might be having these issues, what is the reality of going to get help? And so would they first go to their pediatrician? Would they then go to a specialist? How much of that can be realistically could be covered by, you know, whatever insurance? What are the realities of someone seeking treatment for addiction or for mental health? Like, where does that money come from? And Zach, you may have some sense of this too. You've done reporting on sort of the realities of this. What does it look like right now in 2019, at least in the U.S., for someone dealing with these things?
Well, so there are too many uninsured people in this country, too many people who are underinsured in this country, and I think getting into like healthcare policy and portraying that rightly in entertainment narrative would be quite difficult. But I do think that having conversations about insurance do work and is done in Six Balloons. Did anyone see Six Balloons? It's like a day in the life of a heroin user played by Dave Franco, and Abby Jacobson from Broad City is his sister, and they take him to detox, which is kind of the wrong thing to do. Detox for opioids is not really a thing, but they take him to detox, and there's this whole rigmarole because insurance isn't paying for it, and they don't have the right coverage, and then someone says, well, go down to this clinic, they might have the right coverage. And so I think that's actually a very realistic run-in with the bureaucracy of American healthcare, and I think that I think that's actually very, very realistic, because I think people do have a lot of trouble finding what's in their provider, what's out of their provider. I think health insurance adds a very complex layer to this. We can also get into parity. Insurance, you know, doesn't, or it's forced to, but sometimes doesn't cover mental health as it should, like they do with physical health. These things are separate, and I think it's very critical that we don't separate these things, that they're all part of hospital treatment and primary care, and that these are all treated by doctors, like this guy.
Mm-hmm. And when they aren't treated by doctors, though, I mean, I think there's a very common experience that I've even had working with young adults, even in Los Angeles, which is not, you know, the poor rural area where I grew up, in that people, like adolescents and young adults, want therapy, but their parents can't afford therapy. And it's like this lament, the young adult lament of like, I want therapy, but or you're 26 and you're no longer on your parents' insurance and you want therapy and you can't find it. And it's really sad, but this is actually, and this, I don't want to get too tangential, but this is where the social media platforms actually can be a positive, because I'm not saying anybody should go get therapy on a Facebook group. The kids don't use Facebook anymore. I don't know, that's what I'm talking about. But there are, you know, Reddit, I don't know, what listservs somewhere. Kids are able to find kind of support groups, and I, through some of my clients, and I also have 2 teenagers, have been able to like look into some of these online support groups, and they're not terrible. You know, the kids are like offering each other some support and some good advice, and And it's really interesting how the support that our community is offering is changing in this way because of social media. Social media is not all bad. There's actually some really positive things that can come from it.
So I don't go to AA or NA meetings, but Twitter is my support group.
There you go.
No joke.
Yeah.
A bunch of my good friends on Twitter are in this room, and we are always on it, and we're like working together. We're part of something bigger. It's really important to me.
Yeah. For young kids, I had 3 in my clinic that were pretty recalcitrant and very difficult to treat, and I started playing video games with them on Xbox, and we would play Halo and have a closed chat, and actually they told me everything there. But when I was in front of them as an old guy in front of them, they didn't want to say a word. They were clammed up. But when I gave them my gamer tag and they came on and we literally sat down and played Halo, in the evening sometimes, I got everything from them, and then they would come in and tell me more there. And so it's about building a connection, and which means you have to break down these preconceived barriers with kids. And I think we don't really we haven't built a system for that. We built a system for adults that we somehow adapted to kids, and it doesn't really work. And I use this now even with my kids. When I'm on the road, we play Apex and just can chat, and they'll tell me more things. So I think there are some things with gaming and social media and the new path that have real potential to make big change. And just kind of throwing those out there as nuggets for what connects to kids, and allowing kids to inform that, because the minute that they break down those walls, they're ready to talk about stuff. They don't like where they are, they're frustrated, they're scared, they're sad, they want to be successful, they want their peers to see them in a certain way, and they hate that they're being seen as this person. But the minute they're that person, they'll fully embody it because they have this need to own it, which at many times can rapidly create severe illness in them. And so just figuring out these other ways that we can come at it would be really important.
Classically, we talk about our protagonist, generally our hero, who is the character who's going on a journey, the character who's changing over the course of the story, and there's an antagonist. And sometimes we think of that antagonist as being a villain, like the bad guy of the story, but it sounds like what you're describing really is a therapist as antagonist, the person who is helping the protagonist change, is causing the change. And so there can be friction there at the start, but ultimately you're trying to get to a relationship there so that you can help this person get to the next place. That sounds like the nature of that relationship there. Yeah. Great. We are mostly talking about characters, but we are also writers who have minds ourselves and sometimes deal with these issues ourselves. So before we get to questions, I want to ask you guys, if someone's watching this on the Facebook stream or they're here in the audience and they're saying oh, you know what? I think, this is making me realize that I may have a substance use problem, that I may actually have some mental health thing that I should be doing something about. What is the thing they should do tonight? What is the first step that somebody who is watching this or listening to this should be doing? If they have that moment of awareness.
Don't go to Google.
Yeah.
I mean, honestly, this is the problem, because at this point in time, mainstream medicine is still really crappy at this. The vast majority of people aren't really trained. It's not mandated in medical schools for a doctor to be trained. I'm board certified and I've done it for over a decade. I feel comfortable in the neuroscience of it. That's kind of not the average person who sees a patient when they walk into a hospital, and there's still this stigma that we have to break down. And so what I would say for a person in here first is, get my LinkedIn and call me, I'll hook you up. I know everybody who does this work. Honestly, it comes down to a provider being available to help a person in need, but more importantly, a friend being willing to walk with them through this. And I think that's one of the biggest pieces. And you talked about not only the character, but the people around them. Yeah. The thing I've never seen portrayed truly effectively is a non-family member friend having a truly empathetic connection with a person with addiction to help them take that next step, what we call the transtheoretical model of change, and moving them from this pre-contemplative state to actually going and get help. And it's very simple. It's really, you look at them and you say, I care about you and I have your back. It's that, because they feel so isolated that they don't do it. And as a physician, when I say that in the emergency department, it's amazing the switch that flips in people when I'm treating them in a time of crisis to actually want to get help and just, kind of empty themselves a little bit at that point. And so I think the biggest thing that I would say is Yeah, I could give you the one-liner of go to the SAMHSA website, Substance Use Mental Health Services Administration, and type in your zip code, and it'll give you providers. Or I could say go to the if you feel unsafe. But I want to find the person you trust the most and connect with them, and ask for them to walk with you through this, and they really will. That's the first step, and then together you can start to find the pathway for treatment because it's not predictable yet. We're just now building these systems appropriately, and that's why these billions of dollars from federal government are coming in, because the systems don't exist. It's been kind of a on your own pathway, and so don't let it be on your own. So the first thing is to make that strong connection with the person you trust the most, and then start the journey together. And that could be a family member, it could be a friend. Whoever doesn't trigger you and enable you, identify them, not the person who just says yes to whatever you want to do, but somebody who cares about you. And I think that's the first step that I would say for anybody in here who's struggling with this. And you know what? 10% of you are. And so this is just a reality. And so that would be it. And honestly, find me and call me. I'm happy to answer those questions. We do that. I still have my homeless population in Camden that I see that still calls my cell phone sometimes randomly. Those are interesting phone calls.
And as the therapist, I'm
Yeah.
going to say if somebody feels like they might be struggling and they don't know, if they are and they're wondering if they should take that step to reach out, to take a really deep breath, to love yourself, to understand that we are all experiencing pain and we're all going through something, and that it's okay to be struggling, and that you deserve a good life and happiness, and allow yourself to reach out for help, because sometimes that's the very first step that has to happen, because the self-loathing is so great that people feel like they don't even deserve to be able to ask for help, and that's sometimes the biggest hurdle. Love yourself, allow it to be. We're all human, we're all in this together. None of us really knows why we're here, right? And we're doing the best we can, and it's okay to be struggling, and it's okay to need help.
Zach, as a writer, you're often dealing with the struggle of getting stuff down on the page. Is there any special thing you want to say about sort of the writing process and sort of how it ties into these two things, and sort of the desire to sort of recognize when you need help? Is there anything that's different about that?
So I work from home, and I joke that I'm a stay-at-home dad with no kids, and so it's really nice that I have a partner, Logan. She gets home at around 5, so I try to simulate as best I can a 9-to-5 job, because if you're writing, it's not 9 to 5, and it's whenever you get an email, or it's whenever someone shares the doc and you're in it. So I think because things are unstable and not exactly steady, I would try my best, and this is just what helps me is get structure. I think any writer, I think, is very obsessive, reading the same sentence 100 times and doesn't look any different, and I keep reading the same sentence. I think there's just part of the process that for someone like me who has had addiction, that I have found a way to channel some of the obsessiveness that is part of addiction into something that I think is helpful and something that I think is useful. So that's sort of, I don't really have a big writing process, because journalistically things are just moving too fast sometimes to have a cup of tea and put on the right music. It's like, no, it's just like
a deadline.
I just gotta go.
Gemma, you get to work. You don't have to work all by yourself, because you get to work with a staff. So, but there must be some aspect of the caretaking that you guys are doing of each other and sort of watching out for each other. And there's the whole production of the crew that makes your show. As a person who's managing these people, how do you look out for these folks, and how does a writer on your staff, how could she feel comfortable speaking up if she's struggling, if she's having an issue? What guidance could you give to somebody who's on a writing staff, not yours necessarily, but in general, what could they do? What should they do if they're struggling?
Well, first of all, I mean, in our room, we get taken care of so well. We are fed and watered and coffeed, and we over hiatus, I almost starved to death because I didn't know how to get lunch. Sort of a joke, but not totally.
I know it.
So So I think self-care in general is so important, and I think I don't know necessarily about other people, but I know for myself there's a lot of gymnastics that I have to go through to get to the point that I can I don't know, find the funny, and I've had to face a lot of stuff and deal with a lot of stuff on my time and get through that, because if I don't get through that, I'm just going to come in to work and weep and I need to find another way, so there's, I do things every day, I try to meditate before work. I try to get some exercise in. I try to do, that book, The Artist's Way.
The 5 minutes.
The 3 pages of, I'm on, week 1, year 8. I've never gotten past week 1, but week 1 is great because she talks about the morning pages. And I do that, which is like the 3, and if I take a moment a lot of moments, 30 moments in the morning to do that, to just write down the voices in my head that are like, you don't deserve anything. If I can just write that down so that I don't bring that into the room, I do so much better. And my husband and I have a deal. If I meet an untimely death, that he will never read my morning pages notebook because he will so worry about what I was going through. But it's just that, that yammering to get that out. And then certainly if anyone is in our room is going through something, I think that we give them the feeling that they can come to us and that, there's a lot of trust that has to happen in a writer's room, and you're sharing your personal stories and experiences, and some of them are funny and a lot of them are not, and you need to be able to trust that is sort of a sacred space where that stuff isn't going to get shared elsewhere. And the people in my room know me really well. They know a lot, and there's something wonderful about that. It's also difficult sometimes because they know me really well, but I don't know. It's a very cool relationship, So that's right.
Now, usually on the podcast, we would do a one cool thing, but for tonight, I wanted to do a new segment called Please Stop. And so I asked everyone just to prepare a please stop for something that they see in films and television they wish they would not see ever again, or people would cut way back on. So here's my please stop. Can we please stop with the actual quantity of alcohol we see people drinking, characters drinking in movies and TV shows? Because it's physically impossible. You see these characters. I mean, this is really an appeal to writers and directors, but also the prop people, and because people will drink just these massive quantities, and we all know that it's like tea or something in there, so they're not actually drinking bourbon, but characters drink so much that they would be dead in some of these things. So if we can all just be keep an extra eye out for the actual volume of alcohol we're having our characters drink, that would be my appeal, and ask to please stop overdoing the alcohol. Gemma, do you have a please stop?
Yes, can we please stop when people are, identifying in a 12-step meeting and they say, hi, my name is Bob, and then everyone says, hi, Bob. I don't like it. I don't like it. It's so depressing, and it's so, I don't know. That's a pet peeve. I don't.
Is it realistic? Does it happen in actual group meetings?
Yeah, I mean,
it does happen. But just because it does happen,
more
I don't need to
energy.
see it.
I think there's energy.
Come in later.
People say
Hi,
hi,
Bob.
but not in that way. I think there's energy and lightness and,
Realism, all right. Yeah. What got?
Yeah, I'd say the biggest one is please stop portraying someone who's in recovery from addiction as having a weakness inherently. And on the opposite side of that, just to add to it, don't portray people who decide not to use drugs or drink as lame. Because what it does is it portrays, one, that those who did drink and it happened to be the thing that made them feel normal for the first time and they develop addiction, but then they went through all the work and frustration and pain and that to get well. Treat them like they've overcome cancer, because this disease has the same mortality rate. So as we start to look at it, they have fought to get there, and they should actually be as someone who's really been through a battle and won. And it should be portrayed positively as this is a person I want on my team because I've seen them fight a fight and win. But on the other side, don't make the dude who's like, yeah, I'm cool, I don't want to drink, is like the lame-o that night. Or I don't smoke weed, is like, boo, you can't go to White Castle. You know, so I still go to White Castle, I don't smoke weed, so it's okay. I mean, and so I just think those two pieces go together.
I think both in our media, but also in real life. I mean, a thing I often say is like, if someone says they don't drink, you don't have to ask a follow-up question. Just like they've said, just like, great, so they can have something else, and let's move on and have a great night. Holly, please stop, or don't stop. Please start.
Yeah, don't stop. Please don't stop. No, okay. Please stop portraying mental illness and substance use disorder as anomalies. Almost 25% of people have a diagnosable mental health issue. I would say, argue millions more have maybe a subclinical anxiety or depression issue. So it's a lot of us, and it shouldn't be like that character has a mental health issue, or that character has an addiction. It's much more ubiquitous than that, and would love to see a more realistic portrayal of that.
Zach, what's your please stop?
Okay, I would say to stop glorifying DEA agents and criminalizing the U.S.-Mexico border.
You're here.
So, just one thing, the obviously DEA agents, like we make them look tough, and their job is futile, and they're abysmal at doing it. So, let's just not make them cool people.
Thank you, Zach. All right. Zachary, yeah, it's a comedy. Now we have time for some questions. So if you have a question, and a reminder, a question is a question. It's not a story with a question mark at the end. Raise your hand, and I'm happy to call on you right here.
I got a question.
Hang on, we have mic.
Oh, wait, so there's a mic that's going to come to you? How's this going to work?
Speak loud. You need it for the podcast?
We need it for the podcast.
You're going on the pod.
Hi, thanks, you guys. Well, I guess this is for all of you. I'm just curious. I read Michael Pollan's new book, How to Change Your Mind, which I don't know if you guys are familiar with that, but they start talking about drug addiction and the use of psychedelics and other drugs. I haven't gone all the way through the book yet, but I'm just curious if you've researched any of that or could talk about that for a second.
Yeah, so the psychedelic research is kind of resurgent. There was a time in the 60s in which it was actually done quite a bit and looked pretty promising even then. I think that the research that's now coming out looks equally as promising. So I think it's about dosing and timing, and you have to do science. And science is you have to identify whether or not if I give somebody this versus somebody who got a placebo, like a sugar pill, does it work in that scenario? Because we develop an idea of should I use this based on if nobody knows what's happening, do they do better? And if that's the case, then game on. I mean, there's nobody really against this in medicine. Medicine is pretty straightforward. I mean, we just like to see a randomized controlled trial in a population we can believe by a scientist we can trust. And we're like, okay, cool, this is great. And so, yeah, I think it definitely has a future in the mental health. There's a lot of research there where I think for depression and stuff looks
Absolutely.
great.
Depression, trauma, PTSD, it's very effective. Ketamine treatment and LSD microdosing, very effective. And yeah, it's hopefully going to just
And one more
be allowed to be used more. Unfortunately, it's overregulated right now.
One more DEA thing. It's because of the DEA that we cannot research these drugs.
Yes,
So
that's true.
so let's deschedule these so we can actually research and see what kind of potentials they have.
Right.
Another question, right here. Second row. Oh, wait for the microphone here.
Microphone. I've been researching neurofeedback that people do. I did it as a kid, and I didn't realize I was doing it. I was just brought by my mom. But I just listened to a podcast about it, and they claim that there's no such thing as a chemical imbalance. And I'm confused by that because I currently take medication, and it works great. Right. Right. And the neurofeedback, I do not remember working at all
So
for
from
ADHD.
So I'm a neuromolecular biologist in grad school, and so this stuff is really interesting to me. So sometimes we oversimplify things to the point of being wrong. And it's not necessarily an imbalance because neurofeedback has very little to do with the actual neurotransmitter, the chemical, and more to do with actually building certain signal pathways. Because if you do neurofeedback, you're creating a default reaction to a cue. I mean, we know it's the lateral habenula. I mean, we know exactly what part of the brain we're working on because it's the default reaction to a cue that we're trying to change. And so neurofeedback is, I'm feeling anxious, but let's focus on your heart and see if we can decrease your heart rate during that moment. And so that cue would be to switch from being anxious to thinking about this, which would then lay down new tracks that would then lower your heart rate and decrease your anxiety. It's not a chemical imbalance to be depressed because it's a chemical imbalance in the sense that for your brain, the chemicals are a little bit out of whack, and whether that's structure or chemicals, we never know. Because some people have, like schizophrenia is a structural problem, not a chemical problem. It's what we call arborization, which is where over time your brain connects a bunch of nerves. And then it trims a bunch of nerves too, so that you don't have too many, so that your brain can communicate, so you can have internal thoughts while you're having external thoughts. If you don't trim those branches, then you can have internal thoughts way too loudly while you're having external thoughts, and you get a different voice. So it's these changes in structure. So mental illness is not a chemical imbalance unless it is, which in that case it's a lower or higher serotonin. It could be structural or this. So it's an oversimplification. The heterogeneity of mental illness has a lot to do with trauma. Has to do with, is it group trauma, meaning did a whole group of people experience this versus an individual? It changes the whole dynamic of how the brain's wired. So oversimplification, but they're also wrong because they became black and white. So if anybody's black and white in this space, they're wrong. It's all gray because the science, we know a lot, but we don't know everything. So if they're not speaking if they're speaking in absolutes, turn it off because it's just wrong.
And pharmaceutical companies wrote the copy for chemical imbalance. Like, it's not a thing.
All right, a hand right there, yes.
Thank you. The thing I've personally experienced a lot is somebody whose friends and family think they have an addiction or mental health issue, but that person either doesn't think they do or doesn't want treatment. What does the ideal friend or family member do in that situation, and how does that fit into kind of like the timeline of issues that we've been talking about?
Should bug them every day, tell them they have to go to treatment, spend the people around them should spend all their time worrying about whether the person is in treatment yet or not.
Badger.
Yes,
That's
badger.
yes.
That's what works. I'm good. No. Grown-ups make their own decisions, and if somebody's not ready to get treatment, they're not ready to get treatment, and we have to respect that and live our own lives and take care of our own selves, but you can still be there in a way to say, look, I'm here when you are ready to get help. I'm here if ever you want to get help. And you might want to say that every couple of weeks, but probably not every day, right? So that they know when they are ready to get help that you're there. You can't force anybody to be ready to go to treatment, right? Or to get any kind of help. So it's what you're talking to, and I don't want to get too complicated, is actually, though, one of the systemic problems of something that might keep somebody sick, because there might be what we call enablers, and I hate that word, but it's a good word, who are spending their entire lives worrying about that other person, wanting to make sure that they're okay, resentful, right, that they're spending all their time worrying about the other person being okay. And in that system, the sick person almost might want to stay sick unconsciously because they're getting all that attention around them, and there are these weird payoffs. So actually the healthiest thing to do is to step back, be your own person, say, when my loved one is ready to get treatment, he or she will, and until then, I'll live my own life. I'll be a model of setting good boundaries and living my best life, and as long as they know I'm here, that's all I can do.
And from a provider standpoint, we use a technique called motivational interviewing, which is basically a science-based interaction technique. It's like the Force. It's awesome. So, I mean, literally, these are not the droids you're looking for. I mean, you can get someone through just appropriate empathetic questioning, but it has rigid structure in the way in which you approach it. So if you want to know the right way to say things that might help someone move through those stages of change and get ready faster, rarely can a family member do this because there's too much emotional connection and discourse.
Can be shaming. Sorry, Corey.
Yeah.
It can
Yeah.
be a little shaming.
Yeah, it can be, if overdone. But at the same time, motivational interviewing is the basis for getting someone to start to slowly move through these stages of change. And it's the language that should be mimicked if you're going to try to portray someone who's kind of doing the right thing, not overdoing it, but the basics of it.
The last thing I'll add
Yeah,
is if someone is actively using and they're not ready to stop, it's a good time for them to learn about harm reduction. It's a good time for them to find out where the local syringe exchange program is, where they distribute naloxone, where someone around them can have naloxone, which reverses the effects of overdoses, which someone who knows how to do the proper breathing in case this person isn't breathing. So there's ways to keep this person safe and know that they're cared for, even though treatment isn't on the table right now.
That's a huge, important point. If you have somebody in your life who has an opiate addiction or might have an opiate addiction, get some Narcan, right? And you can, will you explain more what that is? And you can get it at your pharmacy. You can ask your pharmacy for Narcan to be there. If there is an overdose, you can help them stay alive.
Yeah, so an overdose is when the opioid or other substance or a combination of substances. In fact, most overdoses are not just opioids. They're an opioid plus like a benzodiazepine, like Xanax or Valium, or alcohol on top of it, and it suppresses the breathing in the brainstem. And so when that occurs, if that's not reversed, then the patient will die because you're not breathing. Narcan, or naloxone, which is a nose spray or an injection. In fact, what's out in the public right now is just a nasal spray. It gets to the brain, it blocks the receptor that the opioid goes to and reverses that. So what it does is it wakes them up and puts them into florid withdrawal, but it keeps them from dying. And that's the important part, because I can never get somebody who's dead well. So we need to make sure that any chance that we have this. My 7-year-old knows how to deliver this. My 9-year-old knows how to deliver it. They carry it in their backpacks. And I live in Ann Arbor, which is not really, a place where you're most likely going to find as much of this at density, but it should just be that ubiquitously. So if I ask the question, how many of you have Narcan on you, it honestly should be kind of everybody, because it is the one thing that literally is a life-saving drug that anybody can give, that nobody's going to steal, that has no street value other than keeping somebody alive. And if I'm walking back to my hotel tonight, you need to be able to give that.
Go to your pharmacy and ask them that you'd like some, to say, I'd like some Narcan or some naloxone, and your pharmacist will help you figure that out.
There are going to be so many scenes with Narcan in these people's scripts. It's going to be great.
That's
it's gonna
good.
Be good.
That's very good. Good. More naloxone.
Question right here. Let's get a microphone.
So, as you know, what happens to people of color who have mental health or addiction is very different from what happens to white people in this country. And I'm wondering what you would like to see be different in the program that we have around race and mental illness and addiction.
Let's talk about both sort of portrayals right now and also reality. So we make sure that we are addressing both things.
So the data is very clear that medicine is racist. Very racist. Not a little bit. This is not unconscious bias. It's racism. And so racism is shown to be systemic in even doctors of color. And so it's not just everybody. It's the field of medicine that is racist. And this has been well studied, and it basically shows that if you are an African American female, you are going to receive the least effective care than we can deliver as compared to anybody else. And the spectrum changes. So poverty, in the appearance of poverty, and color also puts you even below that. And so the minute you come in and you code as impoverished, or you code as African American from that culture, or you code as American Indian or Latino, you're gonna get worse care. And so that's a reality, and I think quite honestly is worth beating up in TV shows. Like, meaning this needs to be called out. I have this conversation with my patients because obviously they're gonna look at me and be like, well, what do you know about this? I'm a white male doctor. I can walk into a room and have immediate power without having done anything, right? That's just a reality of America. And so I think what I would love to see is how to actually have that conversation from someone like me and someone like that to cross that bridge, because it's crossable. It really is. But you have to call out that the fact that the entire system is actually built against that population. And that's a systemic, historical, problematic issue that we're going to have to deal with. And until we really beat it up in anecdote and emotion and story, it's not going to change in the bigger picture. It's a great question.
It is a great question, and something that I wish, we all wish was more addressed in television and film too, because it's just so empowering to make sure that there is representation in our media, mental health-wise too. It's really unfortunate that there is a bias within the system, and there are also cultural biases. Some groups are more prevalent to ask for help or reach out for help, and I wish that story was told more too, because it's really, really important.
Yeah, this panel is set up to talk about stigma, and I think it's also important as we do our research on these things, make sure we're looking at cultural groups and sort of what are the stigmas about these specific things within that group that would cause different outcomes or cause people to make different choices, be it for getting help or other things. So it doesn't stop at sort of doing the research on like what is the issue, but like what is that issue within that culture is crucial, and that's why you have to have representation, in your room to figure out what's going on there. I think we can take one more question, and so I did get everybody in the back. So I see one hand in the back. I can't even really see your face, but I see your hand up very, very high. So we'll get you a microphone.
Thank you guys for coming out. Back to screenwriting. Within the 12-step programs, there's actually a tradition in not talking about the 12 steps in radio, television, and film. So as screenwriters, how do you approach that? Because you would want to be responsible to that. And like Zach said, with the doc he watched, that gave him an unconscious bias on wanting to take methadone. So if, as screenwriters, we do the best that we can or don't, is there, like, what is our level of responsibility, and is there a higher level to the networks and studios to oversee how we're portraying these 12-step programs, or recovery in general?
I can start answering the question, but I think we have very smart people up here who can also answer it, is, I think as screenwriters, we're always looking for that balance of what is realism versus what is the point that we're trying to make. And what you're describing is that sometimes the absolutely realistic version of like what that 12-step program might be like might be, divulging stuff that is not helpful for the community as a whole. So you may want to make some choices that are different. I think you're always going to approach the scene from what are you trying to do for that character? What is the essence of that scene for that character? And there may be ways to use the nature of that scene, or sort of what's the arc of that scene to get at that thing without revealing things that you don't need to be revealing, or getting into esoterica that's not meant to be discussed. But what do you guys think? Like, to what degree is talking about the specifics of recovery, or sometimes the specific of a certain kind of treatment where like you can't walk somebody through the whole thing and you're going to be doing some shorthanding? Crazy Ex-Girlfriend is a show I loved, and in this final season, Rachel Bloom's character is going through a program, and you can sort of squint and probably figure out what she's going through, but they weren't specific about sort of the nature of the program. Is that an appropriate choice to not give it the name? Where do you guys land on this?
Well, I can speak to that. My understanding of that tradition is that it is not to break personal anonymity, but not that you can't discuss the program. So that is a difference, and that we're dealing with fictional characters. And to do it in a responsible way, I think it's definitely important, but that I don't think it breaks that tradition. That sort of the stigma of recovery that I was sort of talking about earlier is something that is real, and it gives people a sense that there isn't hope, and that if you seek recovery, that your life is over, and that you won't find joy or happiness again. And I think that is false.
Yeah, it's not national security. I mean, it's not like you're going to divulge something that's going to make every person with addiction like suddenly worse. I think transparency is really important for all aspects of treatment, both for addiction and mental health, and that because the more we normalize these things, the more likely it's less stigmatizing. And I think hiding it and separating it and keeping it under the covers just continues to perpetuate that stigma about people who are in recovery and what these things mean. And If somebody goes to a cancer support group, then we talk all about that. In fact, that's entire storylines of pathways for people and shows. So I think that with this, it's a step, it's a pathway in their recovery, and sometimes, and for some people, it's not a part at all. Some people, it's a big part. Some people, it's transient, and it just is what it is. So normalizing it as much as you can through the stories that you tell becomes really important for destigmatizing the treatment of addiction and not keeping things under wraps and scary in a sense.
Yeah, I just think anonymity, it's important for people who want to protect their identity, obviously, but I do think we're in, like that book, The Traditions, I think it was written in the 1930s or the 1940s, and I don't think these traditions are mapping super neatly onto where we are now as a culture and society, namely that when there was an HIV epidemic, a saying was literally silence equals death. That was the slogan. And right now there's an overdose crisis where 70,000 people are dying every single year. And I think that there's a lot of responsibility to not be quiet about that and to speak up. And the more that people like me are in places like this, and the more that there's people who use drugs, people who are using drugs, we need to hear from them. And yeah, so I don't think they should be anonymous, but that's just my take.
I want to thank our fantastic panelists for a very great night.